Hey everyone, and welcome to today's Explainer. We've got a truly fascinating topic lined up for you. It's something that literally affects almost all of us at some point in our lives, but today we're going to look at it through the sharp lens of a medical detective. We're diving straight into the clinical thought process behind diagnosing severe stomach bugs. We'll be breaking down exactly how medical professionals tell the difference between a standard, run-of-the-mill case of gastroenteritis and something much, much more dangerous. So you know the feeling, right? It usually starts out familiar and, frankly, miserable. You've got nausea, abdominal pain, maybe a fever, and the immediate assumption is almost always, oh, I just ate something bad, or I caught that passing stomach bug. But the exact question every single clinician has to ask themselves in that moment is this. Is it just a simple stomach bug, or is a common everyday illness actually serving as a dangerous imposter masking the true culprit? To solve this kind of mystery, you really need the right field guide. And our entire investigation today is derived directly from the highly detailed clinical notes of Dr. Mukhtiar Hussain from MedicoInfo. These notes provide a really rigorous, structured framework for looking at acute gastroenteritis, or AGE, and identifying those critical can't-miss diagnoses that love to hide behind similar symptoms. Okay, let's take a quick look at our clinical checklist for today. First, we'll examine the great imposters. Second, identifying the real culprit. Third, we'll go over the red flags you cannot miss. And finally, treating acute gastroenteritis. Let's jump right into section 1, the great imposters. All right, here is our lineup of mimics, along with the specific clues that give them away. Take mesenteric ischemia, for example. This often happens in older patients with vascular disease, and the defining clue here is severe pain that is just way out of proportion to the physical exam. Or consider a bowel obstruction. For this one, the clinician is looking for a history of prior surgery, absolute constipation, and bowel sounds that go from hyperactive to just completely absent. Meanwhile, inflammatory bowel disease, things like Crohn's or ulcerative colitis, often reveals itself through chronic or recurrent bloody diarrhea without any clear infectious trigger. It's like a giant puzzle you have to piece together. Now, when it comes to one of the most famous imposters out there, appendicitis, timing is quite literally everything. When you're trying to tell the difference between appendicitis and standard acute gastroenteritis, the sequence of symptoms matters immensely. It's a classic, highly testable rule of thumb. In appendicitis, the pain almost always hits before the fever, and that pain typically migrates over to the right lower quadrant and gets very tender and localized. But in standard gastroenteritis, the fever often precedes the pain. It's such a beautifully simple timeline distinction, but it can completely change a patient's treatment path. Moving right along to section 2, identifying the real culprit. Time is once again a major diagnostic clue here. If someone gets violently ill with prominent vomiting super fast, meaning a really short incubation period of just 1 to 6 hours, we're more than likely looking at toxin-mediated food poisoning, like Staphylococcus aureus or Bacillus cereus. The toxin is actually already fully formed in the food they ate. Compare that fast onset to a standard viral or bacterial infection, which typically takes anywhere from 8 to 72 hours to incubate in the body before symptoms finally hit. But hey, we can't just blame bacteria and viruses for everything, right? Non-infectious suspects can absolutely falsely present as a stomach bug. We're talking about heavy systemic issues like diabetic gastroparesis, a thyroid storm, or an Addisonian crisis. Even simple medication side effects, things like laxatives, metformin, colchicine, or antibiotics, can cause severe nausea, vomiting, and diarrhea. So checking the patient's medical history and current prescriptions is absolutely vital. And a really crucial part of checking that medical history is looking out for C. difficile colitis. The major red flags to look for here are a history of recent antibiotics or a recent hospital stay. If a patient comes in with those risk factors, along with profuse diarrhea and marked leukocytosis, which, by the way, is a significantly elevated white blood cell count, C. diff suddenly becomes a prime suspect that needs immediate specific testing and isolation. Okay, section 3, red flags you cannot miss. Let's rapidly fire off these dangerous clinical alarms, because if you see these, the investigation instantly becomes a surgical emergency, requiring immediate imaging or backup consultation. Bilious or fecaloid vomiting, that is a massive red flag. Peritoneal signs like abdominal rigidity, rebound tenderness, or guarding indicate serious inflammation inside the abdominal cavity. We also have to watch closely for abdominal distension accompanied by high-pitched tinkles or just complete vowel silence, which can mean late peritoneal. Finally, hematochezia or melena, which is severe bleeding without any preceding vomiting, points more toward colitis, IBD, or diverticulitis. Which brings us to our final part, Section 4, treating acute gastroenteritis. Now that we know what to look out for, we can walk through a very straightforward clinical progression for uncomplicated cases. Step 1 is the absolute mainstay, fluid and electrolyte replacement. And what's really important here is that oral rehydration solutions are favored way over free water or those sugary sports drinks you see at the store, which honestly are usually just too high in sugar and too low in sodium. Step 2 is diet, focusing on early refeeding of bland foods, keeping away from high fat or high sugar. Step 3 utilizes antiemetics, like ondansetron. There's moderate evidence showing it actively reducing vomiting and hospital admissions, though you do have to be a little cautious with very young kids or patients with specific heart rhythm issues. All right, it is time to debunk a medical myth you have probably heard your entire life. There is actually no need for the routine brat diet, bananas, rice, applesauce, and toast. The evidence actually shows that early reintroduction of complex starches and proteins actively shortens the duration of the illness. So you definitely don't have to restrict yourself or your kids to just eating toast and applesauce for 3 days. We do, however, need to issue a very serious warning when it comes to over-the-counter symptom relief. Antidiarrheals like loperamide should only be used very carefully for mild cases without fever or bloody stool. The crucial point here is that loperamide is completely contraindicated if the clinician suspects C. diff, Shigella, Salmonella, or EHEC. Slowing down the gut when these specific pathogens are in there can trap the toxins inside your body, precipitating incredibly dangerous conditions like toxic megacolon. And trust me, that is exactly as bad as it sounds. Now, what's really interesting and honestly vital for patient safety is how this next point flips our standard logic completely upside down. We usually think of antibiotics as the ultimate cure for bacterial infections, right? Well, using antibiotics for EHE0157H7 is actually harmful. It actively increases the patient's risk of developing hemolytic uremic syndrome, or HUS, which is a very severe and life-threatening kidney condition. Because of severe risks like that, antimicrobial therapy is rarely just empiric. We don't just guess. Antibiotics are only warranted for very specific indications. We reserve them for severe disease that involves hospitalization or signs of sepsis. We use them when specific pathogens are positively identified via a stool culture. We also consider them for high-risk hosts, like the elderly, immunocompromised, or pregnant patients, and for prolonged cases where things like Giardia or C. diff are suspected. And in those specific C. diff cases, the culprit antibiotic is stopped immediately, and oral vancomycin or fidaxomicin is used instead. So, as we pull all of these clinical notes together, we reach our core summary takeaway. For most adults and children dealing with mild acute gastroenteritis, oral rehydration and watchful waiting are truly all that's needed. The human body is remarkably good at clearing standard infections if we just support it with the right fluids and electrolytes and give it some time. But you must always reevaluate. I want to leave you with this final thought today. If that pain suddenly localizes, if the fever drags on past 48 hours, or if bleeding develops, will you spot the imposter? By using this structured, evidence-based approach, you now know exactly what red flags to look for. Thank you so much for joining me on this explainer, and keep learning.